Good morning, ladies and gentlemen. I'll present an evaluation of a system for measles and rubella. So in 2006, a Ministry of Health order was developed and implemented on strategies to eliminate measles and rubella. The goal of this was to achieve the elimination of measles and rubella and to maintain interruption of indigenous measles transmission. This Ministry of Health order were updated in 2012 and 2015. The system is a case-based, and to have an overview about the situation in the country, we had the last cases of measles in 2014 and rubella cases in 2012. So the system is quite simple. It has a flow chart taking 3 levels: local, intermediate, and national. From the local is the primary health care, at the intermediate public health centers, and at the national is the national public health center. So the primary health care are reporting, detecting the cases in 24 hours. They're investigating and managing suspected cases. The intermediate level collect blood samples, conduct outbreak investigation, and they analyze patterns and trends. So national level will analyze and monitor, confirm cases, and evaluate national objectives and receive and giving a feedback to the local and intermediate level. The objectives of the study were to describe the measles and rubella surveillance system and to evaluate the key system attributes. And of course, to assess performance and determine how well the system operates to meet its stated purpose and objectives, and to develop recommendations for improving of surveillance system. So all the data were collected from the National Registry of Disease, and it's a national statistic for vaccine coverage and a register of reference laboratory for the lab data. The performance of surveillance system was evaluated according to the last CDC guidelines at the local and national level. Key system attributes which were assessed, it was completeness, simplicity, flexibility, acceptability, representativeness, timeliness, sensitivity, and predictive positive value. The evaluation of quality attributes like simplicity, acceptability, and flexibility were completed by 172 questionnaires from main stakeholders and the users of the system, which represent almost 14% of the users. Were standardized 29 questions with a Likert scale, and the questionnaire were completed and submitted in electronic and paper form. So for completeness, which represented the percentage of the cases in a database without any missing required information by disease region and surveillance unit, were constitute 97%. So in 97%, all of the required fields for demographic, clinic, and lab data were fulfilled. Sensitivity of the system were assessed for the measles 95% and for rubella 100%. And the predictive positive value for our system is quite low, 11.8, but this is a good indicator for the system, taking in account that this is a measles and rubella system which has to be with a main objective to eliminate these diseases. The representativeness of it's taking in account the entire population is under measles and rubella surveillance system, including domestic and foreign ones. So for example, all the cases which were imported were catched by the system, and it's from our neighborhood countries. But timeliness, representative of this indicator was assessed to 70%, which represented the reports which were transmitted to the upper level in 24 hours. So another indicator is the date from the onset of rush to collection and of the samples were in average to 6.7 days. And the average time for availability of the lab results to the reference one, including collection, transportation, and investigation, was 3.4 days. So again, to the qualitative attributes, which we are assessed, it was a standardized questionnaire. For 70% of them were family doctors, which are the main users of this system. 10% users of clinical or pediatrician and infection physicians. 20% of territorial epidemiologists, or 100, and 2% from national epidemiologists from national center. So what we assessed and saw that the system is getting old. So from almost 50% of the staff were aged above 56 years. And the youngest one representative had a very small amount. This age of healthcare workers is only representing the, our sample of healthcare workers who were questioned. So for simplicity, for our users, in 70% are viewed the system is simple. The case definition collection of data is viewed simple for 80% of the staff. And the method of managing data, including time spent on transferring, entering, and backing up the data, the same. But for the doubled activities and working on reporting are 54% viewed simple. And timeline for reporting in 24 hours is viewed more or less simple for 87%. The system is quite well accepted of its users in 70%. Where accept the aim and objectives of the system in 85% and recognize the measures of surveillance system like efficient and want to continue activities for elimination of measles and rubella in 83%. Agreeing that surveillance data of measles and rubella reflects the true situation, it's in only 70%. The system is quite flexible, and it has the overall flexibility 49%, and we only 22% of the staff has the willingness to introduce additional changes or update the system, so they are in a comfort zone. If the case definition or surveillance indicator will support some changes, 34% will have positive attitude. In case of introducing new diagnostic methodology or a new tool, 83 of them will agree on that. And 81% of staff could allocate more time in communication activities and advocacy with population. So, clear responsibility and requirements for measles and rubella reporting system are available at the local and national level. System is simple in design, sensitive, and case definition for measles and rubella are easy to apply. The personnel in general is not so flexible to adapt to the new changes. But personnel or the staff involved in surveillance of measles and rubella is getting old, which could lead in the future to the lack of the staff. So, main recommendation will be to continue training of staff, especially for the new ones, and to encourage and motivate and increase awareness about the importance of reporting and detection of measles and rubella system. And implementation of surveillance electronic system to reduce time for managing data and increase the quality of data, which is essential in our days now. Thank you very much, and thank you for my team, which helped me a lot.
Thank you, Alexei, for this nice presentation. Now, time for questions or comments, please. Yes, there.
Thank you, Alex, for the beautiful presentation. I don't have a question. We've discussed this far and long, so I'm very happy to see that the evaluation was conducted in according with the recommendations. What I wanted to make a comment is that on the last two presentations, we've seen two different approaches and two different methodologies. Yours system evaluation was based on ECDC's recommendations, and the colleague from Nigeria showed the CDC, the American recommendations. What I wanted to say and what I want to comment is that both of these methodologies seem to have a big gap. None of them includes ethics of the surveillance system. And I wanted to stress it as the beginning of this conference was made on the workshop on ethics in public health systems and ethics of outbreaks investigations. So, as some of us here are decision makers, I wanted to ask and start a discussion. Does the group believe that ethics should be included in evaluation of surveillance systems? And of course, maybe your opinion for the beginning, and to hear from the rest during these 2 remaining days. Thank you.
Thank you, Senat, for your comment and question for the floor. I'll say about the approach, which methodology, and we talk about to take ACDC, CDC, or WHO, but due to that all of us are making reports annually to WHO, which includes the essential attributes of a system, and updating is not clearly and scientific to come with it. And the ACDC approach, it seems to me more closely to have an overview, which we never do it. And for the ethics, I'm totally agree. We have to discuss, and maybe we can have a response from the NGO. Yep. Thank you.
Yes, please.
Thank you for your presentation. Actually, maybe it's a comment or a question as you want. You showed that the completeness of data and the surveillance system is almost 100%, despite the accessibility and the simplicity that has been reviewed. It's almost 70 or 60% by your staff. Is your staff highly motivated or committed in order to complete the data with a system that is not acceptable for them, or what is the case? Thank you.
Thank you, Doctor. So the issue is that we are having a standardized reporting form, and which is completely by the staff, and it's required. So they cannot submit the form without to be fulfilled completely. Yes, and everybody are complete to all the fields. It's paper-based. It's a paper-based. And for the flexibility, in generally, the system and the personal, this is not the flexibility of a system, it's how the users are flexible and to adapt to the changes. And this, we know for sure that all of us are feeling very well and very comfortable without any changes. So I think it's a quite psychological thing. Yeah. Thank you.
Thank you very much for the presentation. 2 questions. I would like to know more about the burden of measles in Moldova. Did you have an outbreak recently? When was the last outbreak of measles in your country? And my second question, how did you compute sensitivity? What were the numerator and denominator? Thank you.
Okay. Thank you very much, Nada. The last outbreak were in 2014, and it was 2 imported cases from Russian Federation. The huge outbreak were in 2002, but now we are approved like eliminated country for measles and rubella. For the second question, for the sensitivity, we're having 2 cases which were not reported like false cases, but they were cases, and we identified them in 2011 or 2012. So the cases were catched by media, not by media, by some local, to say, stakeholders.
Any more questions? Comments? Yes.
Yeah, before we close this session, I want to congratulate Alexei. He is a fellow of cohort 2. So you can jump now, and tomorrow you can throw your hat that your person. Yes.
Thank you.
Thank you.